opportunities to address existential issues within the work of rehabilitation psychology. Um, and rehabilitation psychology is typically done within the rather challenging parameters of managed care entities, which are workers' compensation boards and disability management companies, which are basically private insurance companies. I've titled the presentation, Making Meaning from Disability and Chronic Pain, Challenges and Opportunities During Occupational Rehabilitation. Just a brief word of introduction about myself. I'm Alex Kwee. I'm a psychologist with active licenses in British Columbia, Washington, and Illinois. I teach at Trinity Western University. Oh, I'm sorry, I'll speak louder then. The microphone is not working. Okay. I teach at Trinity Western University, and I'm also a program psychologist at Back in Motion Rehabilitation, which is a Vancouver-based rehabilitation company. The majority of my practice is dedicated to rehabilitation psychology. So I'm going to start with just overviewing the objectives of this presentation. First, I want to describe the tensions in rehabilitation psychology between the managed care mandates of treatment and the more existential / transcendent and spiritual needs of clients faced with uncontrollable health events, such as workplace injury and terminal illness. Secondly, I wish to propose that within managed care parameters, the empirically supported treatment modalities of acceptance and commitment therapy and motivational interviewing can be harnessed to help clients to connect to existential issues. An opportunity exists because these modalities are already gaining increasing acceptance as adjuncts to traditional cognitive-behavioural therapy, which is the stock-in-trade treatment modality within rehabilitation psychology. Unfortunately, their humanistic dimensions tend to be lost on the rehabilitation professionals who employ them. First, let me provide some context here to define terms that you'll be hearing over and over again in this presentation. Rehabilitation psychology refers to psychological treatment in the service of helping to restore functional capacities and facilitate return to work after injury or illness. Treatment is multidisciplinary. I work closely with other rehabilitation professionals like physicians, occupational therapists, physical therapists, as well as vocational counselors. Third-party payers are intimately involved in treatment, and these are your private insurance companies as well as state and provincial workers' compensation systems. A word about why third-party payers are involved. Multidisciplinary rehabilitation is a very expensive enterprise, and often it is just not possible without the deep pockets of managed care entities. Psychological treatment is synonymous with cognitive behavioral therapy, right? From the managed care entity's standpoint, balancing cost containment and treatment effectiveness means that they are only willing to fund evidence-based treatment, such as cognitive behavioral therapy within a multidisciplinary context, which has very strong empirical support for both its cost and treatment effectiveness. Okay. The goal of rehabilitation psychology is return to work, pure and simple. RTW, as they call it in the parlance, is a surrogate for treatment success, even though this is not always accurate. So now let me proceed to addressing some of the challenges to incorporating existential issues within rehabilitation psychology. First of all, treatment is time limited, focused on pain management, functional improvement, and facilitating return to work. There simply isn't the luxury of time to go deep into psychodynamic or existential issues. Right? Treatment must be focused on the compensable injury, whereby the psychological component is dealing with concomitant barriers to recovery. These include anxiety, depression, excessive pain focus, and stress that is attributed to the health event. Cognitive behavioral therapy is the expected treatment modality. Now, I just want to emphasize that this presentation is not an indictment of CBT. I myself practice out of the CBT orientation. I'm simply making the point that the toolkit of CBT is appropriate for addressing certain issues within rehabilitation psychology, but it is simply not adequate for addressing certain other issues, such as existential issues and spiritual issues that come up. And yet these are precisely the types of issues that are provoked within clients because of a life-changing health event like a workplace injury or terminal illness. Another challenge is the intimate involvement of third parties in treatment, as I've mentioned previously. Workers' compensation, disability, case managers are frequently poking their nose into treatment and reminding clinicians that their mandate is strictly to return workers to work and nothing else. You know, just patch them up and send them back to work, right? So one of the unfortunate realities is that the managed care ethos of cost containment does and often conflicts with the psychologist's ethic to or mandate to practice according to an ethic of beneficence and care. I want to now walk you through some different types of existential issues that are raised in return to work treatment, and illustrate each type of issue with an actual case from my caseload. Okay, the first type of existential issue is when the client derives his or her identity from work, and work is disrupted by permanent injury. A railroad worker suffers a head injury from a fall and sustains permanent cognitive deficits. Because of his safety-sensitive job, he has been reassigned to safer and less physical work. The loss of his position, which he held for over 20 years, and ongoing frustrations with memory and concentration deficits lead him to question his worth as a person, a male, and a provider. Second type of issue, when the client struggles with chronic pain and seeks to know the meaning of his or her suffering. For example, a client diagnosed with myofascial pain disorder and major depression raises the question of why me? She struggles to find a reason for her pain because she believes, I have always been a good person and never hurt anyone. Not infrequently do we hear clients compare their struggles to those of the biblical character Job. I just heard it again yesterday. Right? Third type of existential issue, when the client's condition leads to anger at God. Faced with intractable pain from a back injury and the recent loss of his marriage, a hospital worker rages at God and speaks of losing his faith, believing that God is punishing him unjustly. And fourth, when the client faces issues of mortality due to fighting terminal illness. An example of this is a nurse is making her second attempt at return to work after treatment for breast cancer. She is hampered by fatigue and pain. She is deeply appreciative of life and wants to understand how to live it to the fullest. Her case manager expressed impatience that the first return to work attempt was suspended and believes that the client is not motivated enough. The client feels that she is simply honoring a commitment to, quote, take care of myself physically and spiritually, unquote. She states, the case manager doesn't get that I want to go back to work, but the big picture has changed. So moving on, I want to speak a little about the opportunities to address existential issues within the parameters of third-party funded rehabilitation psychology. Right? As I've mentioned, two empirically supported modalities increasingly being used in conjunction with traditional CBT are acceptance and commitment therapy and motivational interviewing. How many of you are familiar with ACT? Mac, just a couple of people. Okay, and what about motivational interviewing? Okay. It's a somewhat more long-standing and therefore quote-unquote famous modality, especially within treatment of addictions. These modalities have found application in pain management, increasing treatment motivation, and in promoting medical adherence. Unfortunately, all too often they are applied as technologies in a really mechanistic sense, and their humanistic philosophical orientations are frequently lost on the rehabilitation professionals who employ them. Right? So let me begin by talking about the first of these two modalities, acceptance and commitment therapy, and speaking a little bit about ACT's philosophical underpinnings. Now, ACT is a fairly new development in the field of psychotherapy. It's known as the third wave of CBT, and it calls itself a contextual cognitive behavioral therapy. It has strong and growing empirical support in the literature. The American Psychological Association's Division 12, which is the Society for Clinical Psychology, lists ACT as one of the empirically supported treatments with quote-unquote modest research support, the equivalent of a quote probably efficacious treatment based on the accumulated research evidence so far. The philosophical basis of ACT is functional contextualism. Right? There's no time to do justice to what is functional contextualism, but I would like to mention that the core analytic unit of functional contextualism is what is the ongoing act in context, what the philosopher Pepper calls the common sense situated action. So bearing this in mind, ACT utilizes a pragmatic truth criterion, which is called successful working. The distinctive and successful working basically is the idea that the success of an approach has to be evaluated according to whether it is in the service or not in the service of helping a client to reach his or her personally significant goals and commitments in life. Okay. The distinctive of a functional contextualist approach is to focus on unique goals. And this is in contrast with much of applied psychology and psychotherapy, which is concerned with the level of technique, case in point, traditional CBT. Now, the choice of a goal in contextualism is pre-analytic. The goal is the starting point and the means of analysis. And what this means is that ACT approaches goals as neither good nor bad. They simply exist pre-analytically and they have to be owned as such. Right? The point is frequently made that all psychotherapies, even the most relentlessly rational and scientific of them, like pure behaviorism, all incorporate some implicit value framework. And in being a very philosophically aware psychotherapy, ACT is more explicit than most therapies in owning its values. And exactly what value system does it own? Well, ACT accords central priority to client-defined values, goals, meaning, and purpose. Therefore, ACT overlaps with the vision of humanistic and existential psychotherapies. At the same time, the unit of evaluation is firmly behavioral, right? Assisting a client to act, to behave in accordance with her personally valued commitments is the therapeutic objective of acceptance and commitment therapy. So we go back to the criterion of successful working, where the effectiveness of an approach is evaluated in terms of its successfulness in whether it helps a client to reach his or her personally significant goals and commitments. If not, then the approach must be abandoned. And here is where ACT becomes really interesting and distinguishes itself strongly from traditional CBT. ACT posits that one of the things that needs to be abandoned in some cases is the very reliance on verbal rules that clients reflexively rely on, to solve their problems, right? CBT is an unerringly rational and verbal form of psychotherapy, and the ACT critique of traditional CBT is that the very use of language has the potential to increase the suffering, or at least maintain the suffering of our clients. Okay, and this it calls the language trap, right? And why does language-based psychotherapy have the potential to increase suffering? Well, this is because verbal rules exist within networks of relational frames. Okay, so there's no time to do justice to relational frame theory, which is a psychological theory of language and cognition, which is the basis of ACT, right? But the idea of a relational frame is that one verbal rule, okay, depending on the context, can entail multiple verbal rules linked to it by relational frames. And so to understand what is a relational frame, because you all must be asking yourself, what is a relational frame at this point? Well, think of anything. Just think of anything right now. Okay? Now, because of your reflexive use of language, you are now capable of linking that thing you have in mind to an infinite number of other things that are linked to the thing you have in mind by some category of relationship. Okay? Categories that are described by words such as equivalence, difference, opposite, analogous, past, present, and so forth. Okay? So let's illustrate with a simple experiential example here. Right? What if I told you, don't think about lunch? Whatever you do, don't think about lunch. What are you doing right now? You're thinking about lunch, right? So it's not really, issuing that verbal rule is not really a successful way of helping you to suppress the very thought that I'm telling you to avoid, which is thinking about lunch, right? And this is how our minds work. Because of your reflexive use of language, you are capable of reflexively transforming the one verbal rule, which is don't think about lunch, into the very opposite verbal rule, okay? Because our minds are capable of transforming verbal rules so that one mental action simultaneously entails opposite and contradictory mental actions at the same time. So if we extend this example into the clinical context, then the ACT critique of traditional CBT becomes easier to understand. Okay, so let's consider the case of positive thinking. How often do we, as good CBT clinicians, tell our clients to focus on the positive, practice cognitive distraction, right? And just think positive, right? Now, in essence, this is really the same rule as don't think about the negative, don't dwell on it, right? And the ACT argument is that we are actually setting up our clients, or some clients, to actually be more focused on the negative. Well, this is not a presentation about ACT, and so we're not going to go into detail about the techniques of ACT, but I do want to make brief mention of the quote-unquote technology of acceptance and commitment therapy. Right? ACT entails ample use of experiential exercises, like what I just did, as well as paradox and metaphor, the aim of which is to weaken the literalness of language and reduce reliance on verbal rules to solve problems. Okay? Also to increase acceptance of negative conditions and emotions such as anxiety, and increase the commitment of the client to act in valued directions, even without the negative conditions or emotions being fully resolved. Right? Okay, so let's move on to motivational interviewing. This is a client-centered semi-directed method of engaging intrinsic motivation to change behavior by developing discrepancy and exploring and resolving ambivalence within the client. Motivational interviewing really started as a technique to help addicted clients to change, right, to resolve ambivalence within themselves and take positive steps towards giving up their addictive behavior based on, not any extrinsic motivator like people telling them to do so, like family members, but based on intrinsic motivators that they could identify and articulate. Okay, it is a more long-standing modality than ACT, so I don't want to dwell too much on it, other than to draw your attention to the fact that the approach of motivational interviewing draws heavily from Rogerian client-centered therapy in its emphasis on empathy and acceptance of the client. At the same time, it departs from Rogers through the subtle use of direction to facilitate change within clients. Key principle of MI is that change is motivated by perceived discrepancy which the therapist draws out between present behavior and personally defined goals and values. Right? And motivational interviewing involves assisting clients to define their current and ideal selves and then to pursue movement towards the ideal. So, viewed from a humanistic lens, MI is not only facilitative of positive change, but it is facilitative of change towards self-actualization. Very humanistic. So let's talk about opportunities and challenges of integrating these modalities within the framework of rehabilitation psychology, which is very much CBT dominated. The opportunity is that these modalities are seen as useful adjuncts to traditional CBT in pain management and occupational rehab. And the primary reason for their acceptance is the growing empirical support for their treatment effectiveness, especially when used in a multidisciplinary treatment context. Right? The challenge is that the humanistic philosophical underpinnings, as I've mentioned, are frequently lost on many of my rehabilitation colleagues. In rehabilitation settings where the treatment mandate is dictated by managed care, which is return to work. These modalities tend to be employed as very mechanistic technologies, as means to an end to return clients to work. Certainly, ACT and MI entail techniques, but to consider them only as techniques limits their potential and misses the bigger picture. So I want to end by just revisiting one of the cases that I introduced briefly earlier, and talking a little about how motivational interviewing and acceptance and commitment therapy was integrated into return to work treatment, and talking a little bit about how the case resolved. Handouts. Would y'all like handouts of this PowerPoint? Yeah? Yeah, thanks. I hope I brought them. Handouts are useful because the case is appended to the back of the PowerPoint presentation, and it's not on the screen. If you go to the very last page of the handout, I describe the case a little for you. But first, let me read the setup again. A nurse is making her second attempt at return to work after treatment for breast cancer. She is hampered by fatigue and pain. She is deeply appreciative of life and wants to understand how to live it to the fullest. Her case manager expressed impatience that the first RTW attempt was suspended and believes that the client is not motivated enough. The client feels that she is simply honoring a commitment to take care of myself physically and spiritually. She states, the case manager doesn't get that I want to go back to work, but the big picture has changed. So just for the sake of time, I'm just going to read over the last page of the handout, okay, just to describe a little for you the case and how it resolved. The client received 5 CBT-oriented sessions during her rehabilitation and 8 sessions during her graduated return to work or GRTW program. CBT emphasized the usual issues of pain management, stress management, quota-based activity pacing, cognitive restructuring of work fears, relaxation training, assertiveness, and ability to set boundaries. This was our focus during those 5 sessions when she was in rehabilitation. Nevertheless, towards the tail end of those sessions, it became apparent that the difficulty was not return to work per se, but how return to work fit within the changed big picture of the client's life. And this is reflected in her statement at the end of, the scenario on the screen. A first return to work attempt failed after only 2 weeks because the client was hampered by fatigue and generalized soft tissue pain due to her suppressed immune system. Because motivation was deemed to be suspect, motivational interviewing was applied to assist the client in compliance with activity goals and pain management techniques. It was in the course of discussing personally significant values and goals that the client disclosed that confronting her own mortality had caused her to question the basic purpose and meaning of her life. Even though she wanted to return to work, this goal by itself was not intrinsically important enough. Therapy helped the client to articulate some of her basic values and commitments. She wanted to be a better sister and daughter. She wished to be more committed to her Catholic faith. She wanted to travel. She wanted to visit her brother in the Philippines who was incapacitated by stroke. ACT assisted the client to reorient how she lived her life back to these fundamental valued commitments. She learned to delink pursuing her commitments from her fatigue, pain, and fear. She came to see these as separate verbal events, whereas she had formerly lived under an implied if-then rule, which was, if I can get my health back, then I can go back to the business of living. She realized that she can have her pain and health fears and still choose to act according to her values and commitments. The client articulated her options as, I can do what's important with my fear, or I cannot have done what's important and still have my fear. Therapeutic outcome. The client ultimately completed a second GRTW program successfully. She is doing well at work and has set healthy parameters around her job. She reports to be living the life she now wants, one that is more congruent with her values, and she is less concerned with what people think of her. She talks excitedly about visiting her brother in the Philippines, even though she knows that the trip will be emotionally and physically hard on her. She still struggles with fatigue and pain, but expressed that she has never felt more connected to life. So at this point, I just want to open up the presentation to any questions. Oh, yes, ma'am.
But from the point of view of case manager, not very successful. She's not going on as
Yeah.
I have my mandate.
Mm-hmm. From the point, you're right, from the point of the case manager, it was not successful the first time around, but she did ultimately fulfill the mandate of return to work, even though it cost the company more sessions than they would have liked to pay for. Yeah.
Could you, if had the model and the case manager had a full ACT model in place at the beginning, do you think it might have been able to improve the outcome from the case manager's point of view?
Mm.
Or not? I don't know. This is, I mean, that's a
Yeah, and it's a good question. You know, to the extent that case managers are not trained clinicians, they oftentimes have degrees completely unrelated to health. I've worked with an architecture major, I've worked with a kinesiologist. These people are not well versed in psychology and psychotherapeutic outcome research, right? So they don't appreciate arguments like, ACT is a beneficial modality and it has growing empirical support in the literature. They are very much fixated on traditional CBT because that is what historically, has been the stock in trade modality within rehabilitation psychology. So, I think it's a function of educating case managers on the value of modalities like motivational interviewing and and ACT, but they have to be willing to listen, and many of them are not.
So are you seeing that there's more of a trend towards an acceptance around substitute therapy?
There's definitely a trend, just based on the data that's coming out. You know, um, for example, motivational interviewing is quite a successful modality in terms of promoting medical adherence and helping clients to fulfill their activity goals within rehabilitation, right? Um, and ACT has been shown to be quite effective in helping clients to manage their pain, right? But the volume of data while growing is still fairly limited. So I think it'll take some years for um, the establishment to come around, and recognize that there's more than traditional CBT, which is effective at rehabilitating clients.
Just on the practical side, dissemination, in some of the multidisciplinary teams that I've worked with, evidence tends to be very ineffective in dissemination,
Mm-hmm.
and more effective is real personal relationships among team members.
Mm-hmm.
So when I quote stats to people, eyes tend to glaze over.
Mm-hmm. Yeah.
I don't know if you've had any experience working with case managers or other members on teams. Have you found ways to make the case for this that doesn't necessarily uh, glaze their eyes with statistics?
Mm.
I mean, is there ways that people have heard the message without having to go read the research, I guess is the question.
Yeah. That's really a question of marketing, isn't it?
Yeah.
Right. And something that we're not trained in your standard doctoral program. Yeah, we could definitely do a better job at marketing ourselves, and it's precisely because we don't market true multidisciplinary care. Yeah, and there are certainly good ways of presenting that information across without the use of ample statistics. Mm-hmm. Yeah.
And I think the other issue too is there's a barrier in that there's not that many people trained
Mm-hmm.
in motivational interviewing. I mean, I've actually recently just looked on the website and there's one trainer in Canada.
Mm-hmm.
So, unless you're working for an organization that brings in somebody, there's a lot of people who in the field, would have difficulty accessing this training.
That is true. That's true. Yeah. But there is a growing awareness of motivational interviewing in Canada.
It's used in healthcare and
Yeah.
it's familiar to people.
Mm-hmm. And the good thing is that you don't need a credential to be a motivational interviewer, right? It's like one of the blessed things about motivational interviewing and acceptance and commitment therapy is that the I guess the psychologists who are kind of on the forefront of developing and perpetuating these modalities, um, haven't felt that it was necessary to kind of protect their sort of niche within psychotherapy by having all these elaborate credentialing programs, so it is accessible in a sense that it is easy for a lot of clinicians to have access to the techniques and to learn without a formal credentialing program. Yeah.
Doesn't that mean really you could just, I'm not from the field,
Hmm.
I'm from the coaching field, but me that something like CBT is potentially so broad. Like there's so many different kinds of it. Everybody's kind of got a different sort of flavor of it. And so the case you're presenting almost sounds like you kind of need approval from regulations and authorities to do motivational interviewing in ACT. But do you really? I mean, couldn't you just sort of embed it in your regular therapy, whether you're calling it CBT or something else?
Mm-hmm. I just subsume it within CBT and I say I'm using an evidence-based treatment. You know, I tell them what it is, but I don't go into elaborate details, and they don't really care anyways.
But did the regulatory agencies care? Do you need to prove to them that you're using this type of therapy or that kind of therapy? If you're using MI, which is not approved therapy,
Mm-hmm.
you're allowed to be compensated.
You're in the clear as long as you're not doing dream work and psychoanalysis, I think. Yeah. Yeah. So. Yeah. Motivational interviewing is actually a modality that comes out of the trans-theoretical model of change, the stages of change model, right? And it's a way of developing discrepancy within the client who is struggling with any kind of issue, pain, addiction, depression, anxiety, developing that discrepancy between what is their current self versus what is their ideal self, right? And it's important that the clinician not articulate that discrepancy for the client, but help the client to articulate it for themselves, and more importantly, own their own intrinsic reasons for change, right? Because the research has found that unless the clients are able to see the discrepancy and articulate their own reasons for change, as opposed to having somebody impose the demand for change on them, then clients simply won't change.
Could you possibly illustrate, is this a case that you know well enough? Could you illustrate the phases of change just in her case?
Yeah. I would say that, this was a fairly motivated client. And in terms of the stages of change, what are they again? There is the pre-contemplation, there is contemplation, there is preparation.
Action and maintenance.
Right. Yeah. So pre-contemplation, contemplation, action, preparation, action, and maintenance. The issue with her was that she wasn't really intrinsically motivated to return to work because she was sort of seeing the big picture of her life, right? And she was really trying to sort of articulate her true meaning and purpose for being alive, right? So she couldn't really appreciate this push, and in fact, she was actually resisting the attempt to get her back to work quickly, right? And that was some of the reasoning for why she was not motivated to apply the pain management techniques, because she saw it as a subtle, actually not so subtle, attempt at coercion on my part as well as on the part of the case manager, right?
Pre-contemplation, the time she was resisting, she was not contemplating those interventions, those techniques as actually benefiting her movement in the direction she wanted to go.
Right.
Okay.
Right. Exactly. Right. So a big part of my job in employee motivational interviewing was to connect her use of the activity to her fulfillment of the activity goals, right, and the use of pain management techniques to those broader overarching objectives, right? The things that she valued in life, wanting to be active again, wanting to, be fit enough to do things with her kids, her parents, to travel, right? And it was only when I kind of put it within that larger overarching context that she began to be more motivated to reach her activity goals and to practice the pain management skills. Does that help to answer your question? Mm-hmm. Yeah. Yes, sir.
I was just going to say, quite often what I found in return to work, that's what I do. I'm somewhat like a case manager. You come in, what I find is there's a real disconnect between what the medical process wants, the insurers want, and being mindful of what the client needs. So when you talk about things like loss, acceptance of the disability, those kind of things which you've incorporated within your work, that helps shift that system, right? But I often find that we battle against medical professionals and insurance companies because they have a framework. And the framework is, you had this problem. Oh, you should be off work for, 12 weeks. That kind of stuff.
Right.
And it's an ongoing challenge to shift. And quite often when I find when we use folks like yourself to do this kind of work, it's because everything is just grounded to a halt. And it's just not working.
Right.
So it's quite interesting.
Yeah.
I wanted to sort of follow that. What do you do when it is no longer a compensable injury, when the major medical issue is basically resolved? However, the person still has a resistance to return to work, or feeling like they've been off for so long that they've lost the skills, but the medical injury.
So they're fully recovered, but they just don't want to go back to work for whatever secondary gains they might derive from it.
Yeah. And then you've got the case manager saying, well, the medical issue is resolved, we're closing your case, closing your clinic. Like, how does that change your role in getting them back to work, or their motivation?
Well, I mean, there's quite a few instances of treatment failure on my caseload, right? And in which case, I mean, you have no choice but to close their claim and, cut off their disability benefits, right?
You're saying treatment failure, you're talking about the
not having fulfilled the mandate to return to work.
okay.
Yeah. Right. So I'm sorry. Have I misunderstood your question, or have I
Well,
sort of?
what do you do at that point? I mean, is it a simple matter of closing the claim, or?
Yeah, I guess from the standpoint of the case manager, you just close the claim and just cut them off.
It's interesting because the way I would look at that is the insurer may not be involved. Outside practitioners might not be involved. The employer still has a duty to accommodate. So what does that look like? Does that look like a different job, a temporary job, or in fact no job at all? So I think the employer still has an obligation to take that step further.
Yep, and I work in the area where, as an employer, yes, we accommodate. And if the person can only work 50%, then that's fine. However, if what they're missing is 50% of their income, and that's where they need to go to the insurance company to fill that one.
Yeah.
But from the employer's perspective, that's fine. If all you can work is 50%, okay. But from the employee's perspective, it's saying you need to accommodate me in terms of I need full 100% income. But that's where the insurance company comes in. And they're saying, no, that the issue is resolved.
Yeah, it depends. I mean, sometimes what we'll do is we'll go a step further and ask for another independent medical. So then what we're doing is we're saying, yes, this medical piece is resolved. However, there is this ongoing other piece, psychological piece, that's interfering, that's getting in the way and creating that problem. Sometimes we're successful, sometimes we're not.
But where does that lead you, though?
So it goes back to an appeal process with the insurer.
An appeal process.
And sometimes I got to use back in motion for those kind of assessments further on to make that connection to say that yes, there's a physical injury and there's a psychological injury, and how do you bring those two together? Because sometimes even though you can talk to, let's say, Sun Life or one of the other insurers about it, they got to see it, and so often you can use independent evaluations to get that kind of information.
Why is the person's medical practitioner not communicating that to the insurance carrier?
It's a $64,000 question.
Well, I'm glad that I had you to defer that question to, since you're an actual case manager. So thank you.
Jennifer here? Okay.
Yeah.
So
Okay.
just in terms of the time, not to cut off.
Okay.
This is where the interesting conversations start, right? There's additional, the how-to, but
Yeah.
good. And I just want to make sure that we have a chance to transition. Thank you.
Absolutely. Yep. Thank you.